Assalamu alaikum. Today we are here. This is an important session. That's I think the crux or key. Every interventionist wants to do CTO and calcified lesions at their stage and their career and want to peak in it. So today's our talk is approach to chronic total occlusion and calcified lesions. And in this presentation, it will be the brief background discussion about the CTO and calcified lesions, and then further we will discuss the cases with our worthy panelists and share their experience, our experience, and experience of our seniors also. So moving to next regarding, I'll first start from the calcified lesions. So in calcified lesions, we used to investigate and grading the calcified lesions according CT angio, but more commonly we practice interventions. So see the calcium on fluoroscopy or of the left heart during the interventions, and by intracoronary imaging with IVUS and OCT. So discussing the benefits or advantage of the IVUS, it can detect the superficial and deep calcium, and by detecting deep calcium, IVUS has the acoustic shadow. Intravascular ultrasound can't detect microcalcification and unable to detect the calcium thickness. But the OCT can detect micro calcium and also the calcium thickness, and having high resolutions but limited depth penetrations in it. Regarding the quantification of coronary calcification, OCT has edge on the IVUS because the intravascular ultrasound semi-quantitatively grade the calcium distribution, localization, and length, but the OCT can quantitatively grade the calcium distribution, localization, and thickness, and are all detected. So the upcoming slide is the revision of this in other way. So the coronary lesions with high calcium content can be detected, severe coronary calcium can be detected angiographically on IVUS and so, but the thickness of calcium and are best detected on OCT. So this is the pictorial presentation regarding in picture A, figure A is a luminal calcification on IVUS, and the deeper calcium in the deeper layers in figure B, and in 180 degree in figure C, it's the calcified lesions and the concentric calcium in the end of here. So after discussion regarding this, I'm moving to a case. It's an important case. Giving you the background of this case, this this patient was 80-year male and probably retired judge, and he has anterior wall MI and presented for primary PCI. Ballooning was done, but stending not done, and patient was discharged from the hospital and came again after 2 weeks with the typical chest pain. So plan was to proceed, then recath, and further elective plan was done. So that plan, after showing the two view of this case, I will discuss with our worthy panelist, and Dr. Romana is here. I will discuss first with this young interventional cardiologist about the approach of this patient. So this is the first view of this patient. As I mentioned, having failed or suboptimal prior PCI, and now again patient present with the typical symptoms. No stent was done previously, only BOBA PTCI was tried, and this is the iocardial view. In RCA, there was 90-95% disease. So our plan, what we have, so I kept limited views in this. So to show you another view, and I'll ask further your approach regarding this patient, and patient is of intervention. So we are not talking about there's a heart team or so. So patient is on table, and you have to plan accordingly for your intervention. So this is another view, and this is the first view, as I mentioned. So, Dr. Romana, how you will proceed to this patient? As highly calcified lesions, there are two approaches to discuss. One is balloon-based technique, and
Thank
other
you so
is
much.
Didi.
Can you all hear me? Yeah, thank you so much, Dr. Bashir. You have given a background that we'll be discussing calcified lesions. You can, on this angiogram, see a heavily calcified LED. The flow is compromised, a tight lesion. And the question that you asked me, I'd like to say that you have kind of given the answer yourself. We have already attempted once doing ballooning in this patient. So a failed PCI would warrant another technique to be used. Now we do have multiple options available. First, I'm sure an NC balloon did not cross this lesion, so we could. There are other specialized balloon also. Of course, there's a problem with passing it down into the LED. So we could think of atherectomy options.
Okay, if we are planning for atherectomy devices, so what are the coronary lesions which require there's an indication for rotational or orbital atherectomy device?
Okay, so for rotational atherectomy, a failed PCI with balloon dilatation, an uncrossable lesion, an undilatable, where you could cross the balloon down in the lesion, but it did not yield well. So those are the cases in which you would, unless there are any contraindications, you would consider doing a rotational atherectomy.
So it's okay regarding the indication that there should be the limitation when we have to stop in a procedure. So what do you think during intervention, what are the limitation or contraindications for rota atherectomy devices?
Contraindications are, there are certain absolute contraindications and some relative ones. So it's important to know absolute contraindications on our fingertips. For a rota ablation procedure, it's important that you're able to get your wire down across the lesion. Only then you can perform the procedure. So if you fail to get your wire across, then that's an absolute contraindication. In SVG grafts, rota is not performed. If you see a thrombus or a dissection, then you'd not go ahead with rota ablation. You could, maybe if you did ballooning, there was a dissection, you are still not satisfied, maybe you could wait another 3-4 weeks, get the patient back on the table again and try rota. However, when you have angiographic evidence of a thrombus or dissection, you would not go for a rota ablation. Relative also, if it's patient has low EF and it's the only surviving artery, so you would not do rota. Some relative contraindications would be if you do not have a cardiothoracic backup, if patient is in shock, has poor LV.
Okay, Dr. Romana, I got your opinion regarding this. Moving forward, this patient was wired, and can we discuss here with the expertise of, sorry to say, we have a lot to discuss here in 45 minutes, and I'm sorry. If you want to ask the questions, we will take your questions in the end. We did rota in this patient. What burst size is required on the base of the angiographic lesions, which we are seeing in the what burst size is required for any patient and the end.
Okay,
so how do you decide the burst size?
Yeah, so this is part of the pre-planning of the procedure. You cannot go in, put in the wire and then think which burst size you're going to use. So because then accordingly you have to plan your procedure, you have to have good backup for management of complications. Also sheath size is very important. So we have different burst sizes. They range from 1.25 to up to 2.5, and most of the cases are tackled with 1.5. The rule is that you have to, burst size should be less than half of the diameter of the vessel that you can see. So you never go more than 0.7 artery to burr ratio. So first, 1.25 to up to 1.75 burrs can be easily crossed via 6 French sheath. 2.0 burr requires a 7 French, and anything above that requires an 8 French burr. So most of the cases you would easily do with 1.5 burr.
Okay. So, one question was with the burr compatibility as per the guide, and the difference between, for example, one device which is rotational atherectomy and other is orbital atherectomy device. So, is there any recommendation for guide size for OA device? Is there any change of you need to upgrade your guide for OA device or not?
I am not aware about the guide sizes for OAs because we do not have exposure to that.
Okay, we will discuss this question in the end. Okay. So, as I'm quick to discuss, we after the rotational atherectomy and did the IVS in this case, and with the support of pre-dilatation and Lesion preparation, even stent would not cross, and with the support of guide liner, we distally placed the stent, and then other stent was placed without guide liner support, and then was post-dilated this patient, and the whole procedure went uneventful and successful. Moving to another case. Today, the first patient was also 85-year young male, and the second patient is also 85-year young male, and we are present in this 85-year male patient, also having the status of failed PCI about 8 to 10 months back. At status 4 that he present with the non-ST and are taken for early NSO PCI. Sequential balloon was done, and there was some complication in that. And after dealing that complication, and patient was then successive pre-dilatation was done even with the 3-ONC, but stent couldn't cross the calcified lesion. So patient, the procedure was deferred at that time without any complications, and kept on follow up and plan electively to do further intervention. So when this patient came again after, this patient remained asymptomatic for 8 months, when again present with the non-ST and heart failure symptoms, and when he present in hospital after the 3 days of admission, it was discussed and planned for further intervention. So here is the further intervention of this case. Before moving to this case, I will ask Professor Rajesh Kumar for further putting light on the complication of, not intervention, complication of rota-related complication. Specifically, you have to tell the audience and me that what are the rota-specific complications and what is their measurement.
First of all, thanks for the compliment. And then a rota complication, definitely this is one of the most important thing when you are doing rota, and you should know about the troubleshoot. And if you don't know about the troubleshoot and how you come out of that, you don't do. That's the prime importance. Apart from the complication which are related with other PCI, like the patient can go into the no reflow or arrhythmia. Typically, if we talk about rota ablation complication, the patient may develop the dissection, the perforation. The important thing is the rota bladder entrapment, burr entrapment, or rota wire shaft fracture. These type of the complication they can be encountered into, and one should know about how to be come out of from this.
Okay, if can you guide us step by step? If there's burr entrapment, how you will manage the burr entrapment?
Burr entrapment, the management, there are several ways where you can retrieve the burr. First of all, you should know what was the mechanism or what was the reason the burr was entrapped. It may be because of the coronary artery spasm. If it is simple, you have to give pharmacology and then gentle pull, with gentle manual pull, it can come out. If it is not, then pass another wire, put another balloon, put a balloon and just proximal to burr, inflate it. It may create certain space and then gentle pull of that burr, it may come out. Sometime this step may fail. You cannot go inside with another wire and another balloon because the drive shaft that having the diameter of 4.3 millimeter, and whatever the balloon you want to track that has 3 millimeter. So sometime it may fail. Then just like we people are doing ping pong technique, pass through another axis, another catheter, and go through with this maneuver. But sometime you fail, then cut the rota shaft adjacent to the advancer, and then mother and child technique, put a guy liner, and with the guy liner you get extra support, and from there you can gentle pull and sometime burr can come out. If this step fail, then another step, senior it. Pass the senior, and with the help of the senior, gooseneck senior, it can pull out. If it is fail, then another. The first option, the surgery should be called, but that should be the last option. First option, involvement of the CTS, but last option that be involvement of the surgery. These are the maneuvers by which we can.
I think
Which bar is more predisposed?
Lowest burr, 1.25. Why? Because this lowest burr, when you burr with high speed, it can go, because the coefficient effect it doesn't occur, it at the high speed doesn't occur as compared to rest. So for that reason, without burring, it can pass through the calcified lesion, and when you want to with the to and fro movement, it usually, because of the calcium before that burr, it cannot allow to retrieve. So sometimes it fails. Yeah, this is also the maneuver. You have to pull the rota wire, and then maybe. And these are the mechanisms.
So you want to comment?
No comments. Let's move on to the next
Okay.
one.
Okay, sir. So moving to this case.
I would like to add another thing about rota. Like we talked about a lot of complications today. Again, what do you do to prevent a complication? Now, burr entrapment we know occurs. What would you do to prevent it? First of all, you need to know that the burr needs to be advanced to and fro with a pecking motion. So if your technique is not right, the rota burr is going to get stalled. Also, make sure before you introduce the burr that the decelerations on the burr are not exceeding 5,000 RPM. If it decelerates within the artery at that rate, then you are more likely to get an entrapped rota burr.
I think just adding one point into it. I mean, like nowadays the Rota Pro is in market, and it has got a very nice, I mean, like feature with it. So whenever your deceleration will go like more than 5,000 or 10,000, so the light will be switched on, and it will tell you that now you have to stop. And just remember one thing, very very important: the packing motion. Where you have a start, you have to finish it. And then you have to remove the foot from the pattern.
You haven't to start within the lesion.
Yeah.
I have a question for Kamran. Suppose that after a zinc stent and this stent is not being when a piece pressure and the stent is not being opened properly and not being optimized. There is still a risk. So can we use this in those cases? if we are suspecting about this is maybe a higher calcium and that is not going to
Okay.
let the stent.
I think you are talking about like in a normal fashion, you are, I mean, like doing your angioplasty and you are putting a stent there, and ultimately you found out that your stent at certain point because of the calcium is not yielding, right? Yeah. So in that situation, I think we have discussed that in the morning as well.
I think
So
we should proceed because there's lot of cases to discuss. If you want to delay it, you will miss many things. So this is the case RO caudal view, as I mentioned, and is the failed PCI. So here there was issue of the guide support. Initially, guide was taken EBU 3.5, then there was issue of support. Then guide was changed to EBU 4, and the initially burr was 1.5. Then burr was taken 1.25, and this case also went successful. So this is a case. Calcified severe proximal and medullary. Do you notice anything here? Anything if near about the radiopaque portion of the wire?
not from the Karachiites. This question should be from satellites people.
No, yeah. This question should be. This is for your eyes to notice it, that what it is. So pre-dilatation. Then we did 2 stents here, and that was the final result. Okay, so here there were 2 cases with us, and now we are moving towards the chronic total occlusion. And with this CTO, I want to discuss the approach of CTO, how we approach to a patient of chronic total occlusion. And my question would be with Dr. Nauman, what are the approaches and techniques to be done in a case of CTO? I'm talking about the CTO of more than 3 months, 3 months or more, not recent occlusion of 1 to 3.
Of course, the definition of CTO is more than 3 months with the TIMI zero flow. Okay, so for the CTO opening, the most fundamental or pivotal thing is the planning. So you have, first of all, you should have a good quality angiogram with dual injection, and the quality of angiogram should be excellent. You have to plan accordingly. So there are 4 kinds of approaches: 2 are antegrade, 2 are retrograde. For antegrade, it is antegrade wire escalation and antegrade re-entry, dissection and re-entry. And for retrograde, again, they are the same. There are certain CTO scores. Depending on that score, you will decide whether to proceed antegradely or retrogradely. Most commonly used is JCTO, which is a Japanese group. So it consists of around 5 variables. So first of all, before proceeding towards CTO opening, you have to look at the symptoms of the patient. How severe are the symptoms? The more severe are the symptoms, more the patient will going to benefit from the intervention. Less are the symptoms, there are less chances that he is going to benefit. So you have to look at the proximal cap, whether it is blunt or it is tapered. And second is you have to look at the distal vessel caliber, whether it is, how much is the caliber.
So Dr. Nauman, we have the algorithms in upcoming slides. I want to share with all of my colleagues to the. So it's about the global CTO algorithm, and on the basis of that we can decide. It's an important rule that dual injection you need for every CTO patient who having the donor collaterals, and the importance of the cape, the proximal cape, whether it's tapered or ambiguity, and distal vessel after the CTO segment, what's the status and quality of that distal segment. And on the basis of that, you have to decide on the presence of side branches there. So on the basis of that, you have to decide, and also the CTO lesion length, whether it is less than 2 centimeter or more. So on the basis of that, you have to decide whether I have to approach antegrade or retrograde. If antegrade, yes, antegrade wire escalation, or I need antegrade wire escalation and re-entry also. So there are 3-4 cases to discuss with this, including retrograde, antigrade, and retrograde techniques. So this is the algorithm we have to follow, and remember, it's important to know. This is a simple version of this algorithm. Also indicates all about what we have discussed here. And the CTO score is Dr. Nauman mentioned. It's important here. It's about to mention about the tip, calcification, angulation, lesion length. It's important. If your score is 2, so your lesion it's difficult, but your score is 3 and more, then the lesion is very difficult. And regarding the complications of CTO, there's also a score progressive CTO complication score. And here age have more points for the risk of the procedure. Which was to be used for the CTO? So should we start with the Fielder XT for the taper tape? If you have the blunt tape, then you proceed with Pilot 200 and Gaia, and further you have to escalate accordingly. The heavily calcified lesions in Confianza Pro 12 and Hornet. This slide suggests the stage of learning or learning curve that one should, whether I have learned today and I should start the retrograde through the epicardial or septals and start to subintimal entry, and so we have to stepwise approach through this. So ideally should progress integrate only in stage 1 and stage 2, and then integrate dissection and re-entry, and then in stage 3 proceed with both. You can proceed retrograde septal collaterals and bypass graft, and in stage 4. And here is mentioned regarding the epicardial, it's the rate of complications are higher, so needs the expertise to deal with it. So discussing the first case, this was 65-year male, known case of hypertension and end-stage renal disease. Because of end-stage renal disease, this patient received renal transplant in 2015. His baseline grade was normal, but estimated GFR I haven't calculated, and this patient present with the CCS 3-4 and with the EF of 35%. And this patient was taken for left heart cath, and nephrologists were on board. So here we tried RCA first, and with the antigrade wire escalation technique, with the support of microcatheter, wire the RCA, and dual injection was not taken as a primary because patient having the issue of contrast-induced nephropathy. So we did this case in 80 to 100 ml of the dye, and we have planned if we need of the dual injection, then we consider, but wire was parked in PD and then pre-dilated with 1.5 and 2 balloon, and then 2 stents were placed in RCA. And after a week of stay, then a stage PCI to LED was done in this case. ये वो दिन थे हमारे जहाँ पे कभी गुर्बत थी कभी अमीरी थी. So with micro catheter support we take pilot 50 and successfully we crossed the year. So can we proceed in this patient antigrade or retrograde?
You should antigrade
First, antigrade first.
There are 2 or 3 things. One is the CTO score. The high it is difficult to cross antigrade.
Okay.
And some other condition like the posterior occlusion of vessel. There is no good guide support.
Okay.
So there is the retrograde, there are good septal collaterals. There is the origin of occlusion, there is a side branch, in which also there is difficulty to cross the integrate.
So,
Fourth is the presence of interventional collaterals.
So for retrograde approach, as Dr. Mahesh is mentioning, it's important not the presence of the collaterals, but interventional collaterals. So it's important just not you haven't just to pass the wire, but you have to take some devices, especially the microcatheter, and sometime you may need small balloons. In this slide here is the operator has tried first integrate and put the wire probably in the subdermal layer, then start for septal surfing, and with the support of this microcatheter, and wire was parked about at the distal cape of the CTO.
Just to be clear, this is not my case, but I shared it with him so he could show us how sometimes it can be easy. Because if you look at that, the wire just goes down smoothly, goes in the PDA, and then comes right back.
So it's the Corsair catheter and distal RCA with the knuckling of fielder XT wire into subintimal space. What's CART and reverse CART? CART is this is the abbreviation. Integrate. Then the other step was to integrate. Pass the wire and subintimal space, and the pass the balloon and balloon it. So this is all about this case is with the CART and reverse CART. So in other case with dual injection and having the RCA CTO at the mid. Here crossbow catheter was tried but couldn't get success, and then were tried with the fielder XT knuckled and pass in the calcified area. Do you want to comment regarding this case?
Okay, so in this case, form the knuckle, cross pass would go, form the knuckle, and enter. Now the question is, distally, are we able to move it or not?
Yeah, I think this is the same case in which
So now we could cross one open one. So this was more of a start. A loop was formed, crossbars won't negotiate the calcium right where you see the balloon is stuck.
I think that in this case there was rota, so I want to show that. So comment here regarding after passing wire from subintimal to the true lumen, then rota was performed.
So you can rotablate. You can rotablate.
So can we perform rotational atherectomy in when some part of wire is in subintimal layer, and then
I'll tell you. So we did this, and once I had 4 cases, I spoke to Brilakis. I said, I've done this. I thought I was the only one who done it. He's like, I've done well over 50. Okay, right when you think you know and you've done something, there are others who've done it a lot more than you have. So yes, it can be safely performed as long as it's controlled.
Okay.
Because that's why if you make a knuckle using a Pilot 200 and then re-enter, a bigger knuckle could be subadventitial. And if you are subadventitial and you bore over there, then you're going to perforate. But if you are mostly in the media, okay, and you're stuck, then people have done it numerous times. There's nothing fancy about it. Maybe 8 years ago it was, but not anymore.
So after rotational atherectomy, put probably 2 stents here, and this is the final result of this case. Moving forward, lesson from this case: subintimal passage can be difficult even with the strong support. Sometimes you may get help or get rid of with the help of rotablation. So in other case, 54-year construction workers with the resistant angina, several previous attempts of RCA CTO was unsuccessful, and here is the case. So dual injection, collaterals from, I think आपको भी नजर आ रहा है. It looks like bridging collaterals and having collaterals from left system also.
So the mechanism of failure in all previous attempts at other institutions was they would go subintimal and then they would stop. So we knew that would be something that would happen. So here we used cross-pass. In about 20% of the cases, cross-pass would do a last, which means it would go limited subintimal cracking and then re-entry. That is more forgiving because it's a shorter traverse of the subintimal space. But here you can see it is still subintimal. So in this case, we used a Stingray.
So how looks like stingray on fluoroscopically on
Okay, I think
fluoroscopy
we
having
should wrap up because we're well above time. So just quickly showcases. So Stingray was used. It's a re-entry device.
pilot
You
500
either
wires
stick with the Stingray wire and swap to a Pilot 200, or you can keep working on the Stingray wire, but it's a needle, so you have to be careful.
Okay.
So this
So
was,
extended with two
okay, so
strands.
this is an example of anti-grade dissection re-entry.
To cross with wire through the distal cape, this technique is called star 70mm tracking, and other is loss limited integrate 70mm tracking. This one loss is about the stingray catheter. So these are last slide. How knuckled wire acts or creates blunt dissection. So knuckle acts like blunt dissection tool by advancing polymer jacketed wire like Filter XT or Mongo until it proliferates or itself form a loop which can be advanced past the occlusion in the suboptimal space.
Just a quick question from Dr. Hakim. Because I haven't used this Stingray so far. So, I mean, like, is there any marker there? So that will tell you that you have to be medial from that. So, what was your experience? I mean, like, is that marker like helpful or what?
Okay. Okay, so you see those two golden dots. Now, if you see those golden dots and fast, which means that you really see two discrete dots, okay, that simply means, no, so the way you prep the balloon is, the balloon is only the sides, right?
Yeah.
Where the arrow is, those are sides, okay? So you can think of it two cylinders. So the key to Stingray is you only inflate it at 4 atmospheres, okay? So those two cylinders to the side would light up. The middle of the balloon is hollow. That is not a balloon. Only the side ports are. So if you can think of the artery, it just sits flat with two portions. So if you see two dots which are at two edges, just imagine at 3 and 9 o'clock of the artery, okay? That means that you are looking at the artery and fast, okay? Now you have to change your angle until you just see one balloon. If you see two balloons, that means you can't stick because you don't know which way to go. Once you see only one, which means that the other balloons are on the other side and they're in plane, then you take a retrograde injection, and then you can tell, do I puncture inferior or superior? Okay, so again, this is a very technical thing. Unless you've used it, I can tell you all about it. It's just like anything. Explaining won't cut it. I've got Stingray balloons with me. Inshallah, we'll use them.